Should we start?
Yes, please start.
Okay.
Yes, ma'am.
Hi, yes, ready. Achaya from Thailand.
Okay, great.
Good morning, everyone. I'm Professor Dr. Samda Sumro. Professor Dr. Samda Sumro, consultant cardiologist at Jaldin University Hospital. It is my pleasure to welcome you all to the APSC Cloud Forum at the in the cardiovascular diseases today. We delve into the critical topic, that is window of the opportunities for lifetime cardiovascular risk reduction in women with the adverse pregnancy outcomes. This webinar aims to shed light on the adverse pregnancy outcomes, APO, which include both maternal and fetal complications like gestation, hypertension, gestational diabetes, preeclampsia, eclampsia, spontaneous preterm birth, fetal growth restriction, and predicting high risk of the atherosclerotic cardiovascular diseases. Heart failure, stroke, chronic kidney diseases, and vascular dementia are again consequences of the APO. Yet the interventional strategies in the peripartum, postpartum periods to reduce the APO-related maternal morbidities are still pending. Much work has been done on this aspect. In the present webinar, we will look deep into the critical window of the intervention, gestation, and postpartum hypertension management, gestational and the postpartum diabetes management, and postpartum weight management. The goal is to promote a systemic strategy to reduce the lifetime risk of the cardiovascular disease in women complicated with the APO. We know that the APO in women is more common in low middle class countries of the South Asia. So this is very important topic which we are going to discuss today. As I have earlier said that I'm Professor Chandra Sumuru. I'm working as a consultant cardiologist at Jaldin University Hospital, KDLB branch Karachi. I'm the coordinator of the GORAD program for the women in Pakistan and chairperson, Scientific Council of Women with Heart Diseases, Pakistan Cardiac Society. Our co-chair is Dr. Ning Young, assistant professor. She is working in the section of the cardiology department of medicine, Chang Gung Memorial Hospital in Taiwan. I will like to invite our director, Dr. Julin, to speak on this, a few words about the this webinar and the topic which we are going to discuss today.
I think the whole session will be in your hands, no problem. I'm so glad to organize this section. I have all the participants here. And the disclaimer is we are going to be following on is the content of the webinar is copyrighted by the APSC. I should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar those of the faculty members and do not necessarily represent those of the APSC. The housekeeping information is the live streaming content of this webinar will be made available via APSC Crowd, APSC Facebook, and also APSC YouTube and APSC Crowd YouTube. Please do, and we can start now.
Okay. Without wasting more time, I will like to introduce Dr. Amber Ashraf. She is professor and head of the cardiology department, Faber Medical College, Faber Teaching Hospital, Peshawar. She is very well-known cardiologist and a hard-working cardiologist in Pakistan. She remained as the Vice President Pakistan Hypertension League and in various posts in the Pakistan Cardiac Society up till now. Her topic is critical window of intervention to reduce lifetime cardiovascular risk in women with adverse pregnancy outcomes, pre, peri, and postpartum or interpregnancy. Dr. Amber Ashraf, please share your slides.
Can you see my slides?
Yes, we are.
Okay.
Yes, it's visible.
Bismillah Rahman Rahim. Assalamu alaikum. I am grateful and thankful to Professor Dr. Khalda Sumro and the organizing committee of APSC to organizing this wonderful workshop that is the window of opportunities for lifetime cardiovascular risk reduction in women with adverse pregnancy outcome. Thank you, ma'am, for the info. I'm Professor Dr. Amber Ashraf, heading the cardiology department in Faber Medical College, Faber Teaching Hospital. Today, I'm going to talk on the critical this is a critical window in intervention in order to reduce the lifetime cardiovascular risk in women with adverse pregnancy outcome, pre, peri, postpartum. While starting the topic, it seems to be very long and huge topic, but I try to conclude in 18 to 20 minutes. I'm going to touch the scope of the problem, epidemiology of the heart disease, adverse pregnancy outcome, its biological determinants, social determinants, risk factor like conventional, emerging, unique, gender-specific, and specifically the role of genetic factors. The challenging situations which we all are facing, guideline limitation, and then a take-home message. So this is a CDC graphic representation of heart diseases death rates in women age 35 and plus, and it's alarming. How does heart disease affect women? Despite increases in awareness over the past decade, only about half of the women recognize that cardiovascular disease is their #1 killer. In 2019, there was approximately 275 million women around the world with cardiovascular disease, and the leading cause of death from cardiovascular disease worldwide was ischemic heart disease in 47% and stroke in 36%. Globally, the prevalence of cardiovascular disease in women has been declining overall by 4.3% since 1990. Whereas in most populous nations, like in China, it's increased by 10%, Indonesia 7%, India 3%. The situation is alarming, and in Pakistan, 30 to 40% of all deaths are due to cardiovascular disease. We don't have our own exact data, updated one, but that's very important to understand the critical window of intervention is crucial for reducing lifetime cardiovascular risk in women with adverse pregnancy outcomes. It involves specific time frames before, during, and after the pregnancy, emphasizing timely and targeted interventions. As we all know, adverse pregnancy outcomes can arise from stress of metabolic and vascular changes during pregnancy, and there may be a maternal and fetal complications in the form of hypertensive disorders of pregnancy, gestational hypertension, preeclampsia, eclampsia, HELP syndrome, gestational diabetes, placental abruptio, spontaneous preterm birth, fetal growth retardation, and small for gestation babies. The risk of adverse pregnancy outcome with approximately 30% of women experiencing an APO. Gestational hypertension in 3 to 14%, births preeclampsia in 2 to 5%, gestational diabetes in 5%, and preterm delivery in 6 to 12%. So APOs is a separate diagnosis, and all these disorders share underlying pathogenesis, including placental ischemia, maternal inflammation, and vascular dysfunction. What is not clear is whether the APO itself initiates a pathway that results in cardiovascular disease or whether the APO uncovers or unmasks the women's predisposition to cardiovascular disease. APOs have immediate risk to maternal and fetal health and longer-term cardiovascular consequences. As such, the occurrence of APOs provides an insight into a woman's future cardiovascular health. So, APOs ponder higher risk of future long-term complications like atherosclerotic cardiovascular disease, heart failure, stroke, chronic kidney disease, and vascular diseases, as well as dementia. This is a pictorial graph which highlights everything regarding the adverse pregnancy outcome. According to AHA 2023 statement, gestational hypertension increases a woman's risk of cardiovascular risk later in life by 67% and increases the odds of stroke by 83%. Preeclampsia is linked to a 2.7 times higher risk of later cardiovascular diseases. And this is a triad. Risk factors leading to the cardiovascular impairment diseases as well as adverse pregnancy outcome in pregnant ladies, which ultimately lead to future cardiovascular diseases. Gestational diabetes increases a women's risk of cardiovascular disease by 68% and increase the risk of type 2 diabetes after pregnancy by 10-fold. Preterm delivery increases double the risk of cardiovascular diseases, whereas placental abruptio to 82% increased risk of cardiovascular disease. Stillbirth. Most of the clinicians, even the patient, don't know it doubles the risk of cardiovascular diseases. Cardiovascular disease is the leading cause of death in women, and that is the different statistical studies done by American Heart Association, which have highlighted it. And more women are dying due to cardiovascular disease as compared to the men. And this is a trend which is very clearly highlighted over there. These are all the risk factors, the sex-specific risk factors, which are highlighted here. We all know then well-established risk factors like hypertension, dyslipidemia, obesity. And important component is the under-recognized risk factors, which are very important. Biological determinants, we all know, and the social determinants nowadays in this era is very important. Most of the women, they are a working lady. They have some social problems, social roles, cultural influences, marital status, family violence. These all things end up with so many problems and stresses. Do you think are women more complicated than men? Anyone? Yes, I think so. Allah subhanahu wa ta'ala had made a different biological differences in women and men, and that's why there are genetic expressions which lead to a different type of the biological differences. This is a myth. The cardiovascular disease is mainly a disease of an old man. But what our data is suggesting, although less frequent, but the cardiovascular disease occur in young women, and more than 35,000 deaths occur in USA. Women don't need to worry about the cardiovascular disease before menopause. But our today's topic, that is the adverse pregnancy outcomes, all lead to cardiovascular disease and death. These are the young women. So one should have to think that the death rates in women are towards a rising trend due to underlying coronary artery disease, heart disease, and stroke as compared to CA, breast, and rest of the other causes. And that is a pictorial presentation by American Heart Association. Perhaps the most important risk factor for cardiovascular disease is the misperception that cardiovascular disease is a man's disease. And see, these are the traditional risk factors: diabetes, hypertension, dyslipidemia, and non-traditional, where the pregnancy complications, the psychological stresses, and low estrogens, breast cancer, all these are here. Conventional risk factors, we all know very well: smoking, diabetes, hypertension, and in women, the low HDL is more predictive than high LDL. And lipoprotein A can be more predictive in younger women. Diabetes almost double the risk of fetal coronary artery disease and cardiovascular disease. And smoking is associated with 50% of all coronary events. Women and pregnant women who smoke may have a 6-fold increase in the risk of cardiovascular diseases. In women, there is small epicardial vessels which have a diffuse non-obstructive disease, and that's very important. And these are the emerging cardiovascular risk factors where there is a critical window of intervention to look these very well in time in order to prevent the adverse pregnancy outcomes in our young, productive age females: depression, stress, autoimmune disease, and environmental pollution. Inter-heart study concluded that psychological factors is responsible for 32.5% of cases of myocardial infarction and cardiovascular diseases, whereas the risk of developing cardiovascular disease in women with depression is 30 to 50% higher than in men. So, the stress and depression should be considered independent risk factors in women. And autoimmune disease, they are considered a risk enhancer. Nowadays, the cardio-oncology, the drugs, their prevention and therapies is very important. And now we come to the unique cardiovascular risk factors, which are gender-specific. And this is the critical window where when we timely intervene, when we can reduce the adverse pregnancy outcomes. And we all know the polycystic ovary syndrome, the hypertensive disorders, gestational diabetes, preterm, low birth weight, early menarche leading to impaired glucose tolerance, cardiovascular risk, coronary artery disease. These are the young females before marriage. They should have to identify all these risk factors and they should be treated well in time so that they become a healthy mothers later on. And the contraceptive pills is associated with an increased risk of venous thromboembolism, heart attack, stroke, and elevation of blood pressure. Polycystic ovaries have increased relative risk by 5 to 10 times of developing a type 2 diabetes. And it is then associated with cardiovascular disease, whereas hypertension during pregnancy by 3 risk of developing chronic hypertension and pulmonary embolism, twice the risk of more of cardiovascular mortality and double the risk of fetal and non-fetal strokes. Risk of dying from ischemic cardiomyopathy is 2.5 times higher. So it's very important to identify all these unique risk factors which we can identify and manage timely. Gestational diabetes is a predictor of diabetes mellitus in future, and women with gestational diabetes mellitus have twice the risk of cardiovascular disease. Preterm birth is associated with increased future maternal risk of adverse cardiovascular events like cardiovascular death, fetal, non-fetal ischemic heart disease, and stroke. So, the adverse pregnancy outcomes approximately occur in 30% of the women, experiences gestational hypertension in 3 to 14% of the birth, preeclampsia in 2 to 5%, gestational diabetes 5 to 10%, and preterm delivery in 6 to 12%. Adverse pregnancy outcomes have immediate risk to maternal and fetal health and longer-term cardiovascular consequences. As such, the occurrence of APOs provides an insight into a woman's future cardiovascular health. It's very important to know the risk factors because one risk factor doubles the risk of cardiovascular disease. It has a multiplier effect. 3 or more risk factors can increase the risk to 10-fold. Adverse pregnancy outcome can significantly increases the risk of cardiovascular issues later in life, highlighting the need of proactive measures. And the evidence from different studies have already suggested a strong link between the two. So the three important categories, that is the genetics, environmental exposure, and lifestyle factors, are very important to understand. The environmental and lifestyle component of coronary artery disease, cardiovascular disease have been well documented since 1960, and the guidelines have been standardized for these detection, reduction, and management. However, cardiovascular disease is a pandemic and can be prevented. Conventional risk factors are inadequate to detect those who are at risk in the early stage when they are asymptomatic. So genetic risk for cardiovascular disease can be determined at birth, and those at highest genetic risk have been shown to respond to lifestyle changes, statin therapy, with a 40 to 50% reduction in cardiac events. So genetic risk stratification for cardiovascular disease should be brought to a bedside in an attempt to prevent this pandemic disease. And that is the point where we start doing our primordial preventions. Primary prevention is preferred, knowing that the 50% of the population can expect a cardiac event in their lifetime. Risk stratification for primary prevention using AHA predicted 10-year risk based on conventional risk factor for CAD is less than optimal. So the genetic risk score is the answer, which is estimated for the recently discovered genetic variants predisposed to cardiovascular disease, offer a potential solution to this problem. And so the study performed more than 1 million individuals, confirmed the genetic risk stratification is superior and primarily independent of conventional risk factors. That's very important. We all should know the prospective clinical trials based on risk stratification for cardiovascular using the GRS, that is the genetic risk scores, have shown lifestyle changes, physical activity, and statin therapies are associated with 40 to 50% reduction in cardiac event in high genetic risk group. Genetic risk stratification is inexpensive and can be performed worldwide, providing a risk analysis at any age, and thus has a potential to improve the primary preventions. So we have all come to know about pre-existing phenotype, adverse pregnancy outcomes, what they are, and how they can lead to the intermediate cardiovascular risk. For this, the evaluation of these patients in pre-pregnancy is very important so that we can identify these risks very well in time and intervene them, as well as the nutritional supports to the ladies who are going to planning for the pregnancies. And third is the exercise regime. Developing personalized exercise plan helps in improving cardiovascular fitness, preparing the body for the pregnancy-related changes. So once the pregnancy occurs and when there are so many comorbid conditions, next we have to look after the adverse pregnancy outcomes and reduce the cardiovascular disease risk. So during the peripartum, the post-delivery monitoring is very important tool, and it should be developed in every hospital so that we can develop these type of the clinics where the cardiovascular screening can be performed at the postpartum stage. Early detection intervention for the potential cardiovascular risk should be planned, and a comprehensive postnatal care should include cardiovascular assessment to mitigate long-term efficacy. That is, American Heart Association shared the workout. Initial 6 weeks, these postnatal females are under cover of gynae-ops people. Then from 8 to 12 weeks, they should be a combined clinic where the gynecologist, obstetrician, physician, and cardiologist, they work together. And from 6 months onward till 1 year, there should be a proper coverage of these patients with adverse pregnancy outcomes so that they can be looked after properly, and we can reduce the cardiovascular risk as well as prepare these young healthy females for the next pregnancy by introducing lifestyle modifications, support programs, and physician follow-up at the regular basis. So when we are going to follow all these steps, The success story will be there. Inshallah, in the end, we can have a healthy mother and healthy child, and we are going to reduce the maternal mortality as well as fetal mortality rates. So, timely intervention offer a long-term benefits by effectively mitigating the impact of adverse pregnancy outcome on cardiovascular health. And addressing the cardiovascular risk promptly significantly reduces the likelihood of long-term complications in health issues. That is the very well-known AHA life essential aids. We all know how to manage our risk factors, our hidden enemies, what our environmental risk factors, how to look after them, and how we are going to address the adverse pregnancy outcomes in order to have a healthier life. We have a lot of challenges, especially in South Asian countries, underdeveloping countries. There is access to healthcare, obstacles, awareness can hinder effective implementation of the intervention. And we are resource-limited countries, and limited resources can pose challenges in delivering comprehensive cardiovascular intervention to women with adverse pregnancy. So this is a form in which we can start developing these type of the clinic, postpartum factors influencing the cardiovascular risk, pre-pregnancy cardiovascular assessment, gestational diabetes, weight reduction, depression, and lactation. Important thing about lactation, the mothers who are doing continuous lactation, they have less chances to develop adverse pregnancy outcomes. Then multidisciplinary cardio-obstetric team should be developed where all the members put their input, and the supplementary non-clinic based interventions are very important. The clinicians as well as the patients should be educated, the home visit, telemedication, and all these things will be helpful. In the end, what is important, the early identification of cardiovascular risk is very important. Comprehensive care and support are essential for long-term cardiovascular well-being, and collaborative efforts among healthcare providers, policymakers, and community resources are really very important. So we start at the individual level, AHA Life Essential Aid. From here, we start developing healthcare professionals, the teams. There should be transitional clinics. There should be a lifestyle modification workshops, proper pharmacological treatments, and the individuals as well as clinicians and patient education, a proper health system should be developed. And then we go to the community level so that we can look after this huge burden of adverse pregnancy outcome diseases, which leads to a cardiovascular disease burden. And we have a large, huge number of non-communicable diseases burden, which has a big impact on our health economics. So this is a high time where we should have our own guidelines in order to address this very important diagnosis, which is diagnosed most of the time, and most of the patients don't know where to go, how to look after their health. And this is the way forward in which we are looking after to achieve the sustainable development goals by 2030 by reducing the maternal mortality as well as fetal mortality. And I would like to request the Pakistan Cardiac Society and the rest of the Thailand Society, the Philippines and the Asian Pacific and all this to come up and have a joint research to find out this data of South Asian population, because we have a different cultural values and we have a different risk factors, so that we can generate our own guidelines and we work on it and save our mothers. Healthy mother can have a healthy home, healthy children, healthy nation, and we will inshallah prosper. Thank you very much for patience listening.
Thank you, Dr. Amber Ashraf, for that enlightening discussion. She spoke about the incidence of heart diseases in women, and she spoke about the gender differences of male women cardiovascular diseases, especially highlighted the problems during the pregnancy, during the three terms, that is peripartum, postpartum, and inter-pregnancy period. So I came to know from her that there are significant, we can change the scenario by genetic engineering, genetic counseling, the genetic stratification. She spoke about the environmental factors. She spoke about the socio-cultural differences in our women of the South Asian countries. So, but we have to take care. We have to take care and motivate our women for attending the counseling clinic, starting from the 6 weeks to 3 months, 6 months, and 12 months. And all those women who are having in the worst outcome during the pregnancy. We are coming back towards the another speaker who is Siska Savendeta Denny. He is expert on the subject, and he will speak on this domain. Dr. Siska, could you shed light on the critical windows and the target blood pressure control strategies during these periods, which are mentioned: peripartum, postpartum, and interpregnancy duration?
Okay, thank you, Dr. Sombro. Let me share my slide here. Give me a moment. Okay. I hope everybody could see my slide.
Yes.
All right, thank you. Thank you for the kind introduction. Yes. And I'm extremely honored to be invited and participate on this APSC Cloud webinar to improve cardiovascular outcome in women with adverse pregnancy outcome. And my topic would be the peripartum and postpartum hypertension management, the critical window and the target of blood pressure control. I have no disclosure related to the current presentation. And hypertensive disorders in pregnancy are one of the most commonly found cardiovascular condition during pregnancy, with a global prevalence of around 10%, and some reference even cited as high as 15%. And it is the second leading cause of global maternal mortality behind maternal hemorrhage, and it poses a significant risk for maternal and fetal complication. When early detection is important, thus blood pressure measurement is recommended to be taken at each and every antenatal visit, repeated as necessary, taking into considerations the possibility of white coat hypertension, which was reported to be found in up to 30% of pregnant women. It is not so different in general population, actually, but since hypertension in pregnancy is considered a high-risk pregnancy, more care should be taken to confirm the diagnosis and the need of antihypertensive treatment. Who are at risk, the observational studies had shown that maternal age less than 20 or over 40 is a risk factor, and also a history of prior hypertension, the presence of diabetes, overweight or obesity, history of smoking, twin pregnancy, and history of kidney disease and history of autoimmune diseases are risk factors. The classification of hypertensive disorder in pregnancy had been continuously evolving, but generally it is classified into these 4 groups. Pregnant women has chronic hypertension if blood pressure elevation precede pregnancy or develop before 20 weeks of gestation. And gestational hypertension is when the new onset hypertension develops after 20 weeks of gestation without evidence of proteinuria or other preeclampsia findings. Preeclampsia and eclampsia is when gestational hypertension is associated with significant proteinuria or other end organ dysfunction. It is worthy to highlight that proteinuria is no longer the sine qua non for the diagnosis of preeclampsia, nor is edema. The current definition requires the evidence of maternal organ dysfunction accompanying hypertension, whether it is proteinuria, liver involvement, hematological, or neurological complications. And the 4th group is chronic hypertension with superimposed preeclampsia. In addition to the 4 groups, a distinct classification for preeclampsia with severe features are the severe elevation of blood pressure with systolic BP over 160 or diastolic BP over 110, and the presence of thrombocytopenia with platelet count less than 100,000 per microliter, the presence of impaired liver function that is not accounted for by alternative diagnosis, and it could be indicated by abnormally elevated blood concentrations of liver enzymes or by severe persistent right upper quadrant or epigastric pain unresponsive to medications. And also renal insufficiency defined as serum creatinine concentration exceeding 1.1 milligram per deciliter or a doubling of serum creatinine concentration in the absence of other renal disease. Pulmonary edema, new onset headache unresponsive to medication and not accounted for by alternative diagnosis, and also visual disturbances. And pathophysiology, it is thought to be caused by abnormal maternal immune response to the invading trophoblast of the placenta, which cause defective placentation. In the normal placenta, appropriate extravillous trophoblast invasion into the maternal endometrium, here shown in red arrow, leads to sufficient maternal blood flow from the spiral artery. Thus, the healthy placenta secretes placental growth hormones, activates the VEGF, and maintain an overall healthy endothelium. But when there is incomplete EVT invasion occurred, it will lead to insufficient maternal blood flow from spiral arteries and subsequent placental hypoxia. And the hypoxic placenta secretes SFLT1, which suppresses VEGF, resulting in systemic endothelial dysfunction and clinical symptoms. And since the origin of this pathology is from the placenta, we could observe rapid improvement of symptoms after placental delivery. But despite the resolution of clinical symptoms, the residual risk for concerning hypertension and adverse cardiovascular outcome after the occurrence of hypertensive disorder in pregnancy is still significant. Other than the obvious risk during pregnancy and peripartum period, the increased risk persists long beyond the pregnancy period. And this is a meta-analysis from Bellamy published in 2007. The study comprised of almost 200,000 women with history of preeclampsia. And the study concluded that pre-eclamptic women have up to 4-fold increased risk for developing chronic hypertension. And further follow-up after that concluded that ischemic heart disease risk was also doubled. So overall CVD mortality, the risk of coronary artery disease and heart failure is also significantly increased compared with normal blood pressure during pregnancy. And today we would focus a little bit more about peripartum and postpartum hypertension. And hypertensive disorders in the peripartum period contribute substantially to the maternal and fetal morbidity and mortality. Around 10% of maternal deaths due to HDP occur in the postpartum period. And women with gestational hypertension or preeclampsia require close monitoring during the peripartum period, defined as the last month of gestation up to 28 days after delivery. And other complications of severe postpartum hypertension include stroke and eclampsia. And one of the major issues in the peripartum phase is the occurrence of hypertensive emergency. The causes of hypertension in the peripartum or postpartum period is, of course, the continuation of hypertensive disorders in pregnancy, whether it is a pre-existing hypertension or a gestational hypertension. If it is pre-existing hypertension, usually it will persist over 6 weeks postpartum. And if it is a gestational hypertension, including preeclampsia, it should resolve within 6 to 12 weeks postpartum. The hypertension could also manifest as a de novo preeclampsia with headaches, epigastric pain, visual disturbances, or seizure. But don't forget, it could also be triggered by iatrogenic causes like drugs. Women are usually sometimes given non-steroidal anti-inflammatory drugs for analgesia, ergot derivative for postpartum hemorrhage, or ephedrine used to correct hypothalamia after regional anesthesia. And when the analgesia is inadequate, the pain during labor also could induce hypertension and also the mother anxiety. And the management of hypertension in the peripartum area at the peripartum period depends largely on the degree of BP elevation and also, of course, the extent of maternal organ dysfunction. Blood pressure level exceeding 160 over 110 had been consistently shown to be associated with adverse maternal outcome like stroke or pulmonary edema. Thus, it is the most common cutoff for diagnosing severe hypertension in pregnancy. But note that the European guidelines use systolic BP cutoff of 170 instead of 160. And the BP measurement should be taken at least twice, 15 minutes apart. And if this level of BP elevation persists after 15 minutes, patient should be admitted to healthcare facility and immediate therapy should be given. First-line therapy for this severe hypertension could be intravenous labetalol, intravenous hydralazine, and if no IV access, we could also use oral short-acting nifedipine. Intravenous magnesium could also be considered to prevent seizures in the preeclampsia with severe feature. And intravenous nitroglycerin is a drug of choice when pulmonary edema occurred in the setting of preeclampsia. Alternatively, IV nicardipine could also be used. Like in Indonesia, we don't have access to labetalol, and hydralazine intravenous is also not widely available. Usually the first line would be short-acting, immediate-acting nifedipine. And if we need intravenous medication, we would proceed with nicardipine. And immediate goal of treatment is to reduce mean arterial pressure by 15 to 25%, with a target to achieve systolic blood pressure around 140 to 150 and diastolic blood pressure between 90 to 100, while trying to avoid underperfusion of the fetal placental unit. On the other hand, if the blood pressure elevation is mild to moderate, we could start single therapy with oral agents, the drugs of choice in this scenario are labetalol, nifedipine, and metaldopa, to achieve blood pressure in the range of 140 to 150 to 90 to 100 millimeter mercury. And if BP are not controlled with the first line of therapy, then consider the second line agents such as hydrochlorothiazide or combination therapy. The ACOG, American College of Obstetric and Gynecology, differentiate the marked BP elevation into severe hypertension and hypertensive emergency. Severe hypertension is when we observe the elevation of systolic blood pressure over 160 and or diastolic blood pressure over 110, measured on 2 occasions at least 4 hours apart. And hypertensive emergency, if there's 2 severe blood pressure values is consistent with severe hypertension taken 15 to 16 minutes apart. And if this is present, begin treatment as soon as possible, preferably within 60 minutes of the second elevated value. And this is again the ACOG algorithm. for the management of severe hypertension and hypertensive emergencies during pregnancy, peripartum, and postpartum period. And the first line usually could choose between oral nifedipine, again labetalol, or hydralazine if it is available. And after we diagnose the severe hypertension or hypertensive emergency, and we decided that we need prompt treatment with antihypertensive agent, we could start with immediate release nifedipine, not sublingually but oral route, 10 milligram. And of course, don't forget to monitor the mother for side effects and the baby for heart rate abnormalities. And the BP should be repeated in 20 minutes. If we still observe the presence of severe hypertension, oral nifedipine could be given again with a dose of double the initial dose, 20 milligrams. And it could be repeated again in 20 minutes, and we could give another additional round of oral nifedipine 20 milligrams. And this could be again repeated in 20 minutes. If after 1 hour with repeated dose of oral nifedipine, the target blood pressure is not yet achieved, consider administered or combine it with intravenous therapy such as labetalol. If the BP threshold are achieved, we should monitor our repeat blood pressure every 10 minutes for 1 hour, then every 15 minutes for 1 hour later, then every 30 minutes, then every hour for the next 4 hours. And this is the algorithm for the labetalol. Labetalol could be given initially intravenously in the dose of 20 milligram, a slow bolus over 2 minutes, and BP should be repeated in 10 minutes. If the target blood pressure is not yet achieved, we could give another dose of labetalol, again, double the initial dose. We could give 40 milligram intravenous over 2 minutes and repeat blood pressure in another 10 minutes. We could give 80 milligram of labetalol intravenous and repeat BP in 15 minutes, in 10 minutes. If after 30 minutes or 3-time administration of intravenous drug, the target blood pressure is still not yet attained, considered combined with another intravenous agent. The ACOG recommend hydralazine for this situation. And this is the hydralazine algorithm. Hydralazine intravenous could be given 5 milligram initially or 10 milligram intravenously over 2 minutes. Blood pressure should be repeated in 20 minutes. Then we could give another dose of hydralazine 10 milligram over 2 minutes, repeat in 20 minutes, and after 2 times 20 minutes, the target blood pressure is not yet attained. If we initially use hydralazine, we should try to combine with another intravenous agent, such as this shown is labetalol. It is important to note that hydralazine is associated with more perinatal adverse effects than the other drugs. However, it is still commonly used when other treatment regimens have failed to achieve adequate blood pressure control. And when do we need to consider delivery? Induction of labor is associated with improved maternal outcome and should be advised for women with gestational hypertension or mild preeclampsia at 37 weeks gestation. And optimal timing depends on fetal well-being, gestational age, and type of hypertensive disorder. And while preeclampsia without severe features is potentially manageable to term, the presence of eclampsia usually requires delivery soon after maternal stabilization. All women with severe preeclampsia should be delivered promptly, whether vaginally or C-section, regardless of gestational age. And vaginal delivery should be considered for women with any hypertensive disorders in pregnancy, unless a C-section is required for obstetric indications. Antihypertensive treatment should be continued during labor and delivery to keep the systolic blood pressure lower than 160 and diastolic blood pressure lower than 110. And what about the postpartum hypertension? In a normal situation following uncomplicated pregnancy, most women will experience elevation or slight increase in blood pressure during postpartum period due to resolution of cardiovascular adaptations to pregnancy, namely the mobilization of fluid accumulated in extravascular space during pregnancy. This blood pressure rise is physiological, and should mild hypertension develop mostly on days 3 to 6, it usually resolves spontaneously without the need for drug treatment. Check blood pressure within 6 hours of delivery in all normotensive women, and then at least once daily in the first few days. Persistent blood pressure of more than 150 over 100 warrant consideration for drug treatment. And in previously hypertensive patients, check blood pressure every 4 hours after delivery until patient is deemed stable, and do not discharge until blood pressure is well controlled for at least 24 hours. And the management for postpartum hypertension, for chronic treatment, we could use the oral drugs. Labetalol is one of the drug of choice. Atherosclerotic could also be considered. Nifedipine, slow release, and amlodipine and enalapril is also drug of that could be considered in this scenario. But for acute treatment, as mentioned previously, hydralazine intravenous, labetalol, and nifedipine should be considered first-line therapy. And the use of antihypertensive agents in breastfeeding women. We know that some antihypertensive agents are more recommended because there's no known adverse effects on infants receiving breast milk, such as labetalol, nifedipine, enalapril, captopril, atenolol, and metoprolol. And antihypertensive agents with insufficient evidence on infant safety are the angiotensin receptor blocking agents other than enalapril and captopril, amlodipine, and the angiotensin converting enzyme inhibitors other than enalapril and captopril, and all angiotensin receptor blocking agents and amlodipine. And this is a summary for antihypertensive medication use in pregnancy, peripartum, and postpartum period. As ACE inhibitor is generally not to be used in pregnancy, here shown in red, but captopril and enalapril may be safe during lactation. Angiotensin receptor blockers again have no place in hypertensive disorders in pregnancy, and contraindicated both in pregnancy and lactation. Beta blockers and combined alpha and beta blockers could be used in pregnancy and also in lactation. Labetalol usually is the first-line therapy, but of course with beta blocker there's always risk of increase of fetal growth restriction, especially apparent with propranolol, atenolol, and metoprolol, but also result in neonatal bradycardia, and the evidence is with nadolol and smolol, and also hypoglycemia. Alpha adrenergic agonist, methyl-dopa is first-line therapy, and in lactation may use methyl-dopa and probably safe to use clonidine. Calcium channel blockers, nifedipine is the first-line therapy. Verapamil and diltiazem could also use. Usually it's not for hypertension, but also for the PSVT. Amlodipine probably safe during pregnancy. And nifedipine is safe during lactation. Unclear about diltiazem and verapamil. And vasodilators, intravenous hydralazine is first-line therapy, and intravenous nitroglycerin is preferred when preeclampsia with pulmonary edema occurred. And during lactation, hydralazine likely safe, and nitroglycerin probably safe, unknown effect with other agents. And as take-home messages, hypertensive disorders of the peripartum and postpartum period contribute substantially to maternal and fetal morbidity and mortality. Blood pressure of 160 over 110, lasting more than 15 minutes, warrants immediate drug treatment. Labetalol, intravenous, and oral nifedipine are currently suggested as first-line treatment for hypertensive emergencies during pregnancy. Labetalol, nifedipine, and enalapril and metoprolol are considered safe for breastfeeding mothers. And with that, I conclude my presentation, and thank you.
Excellent presentation. She spoke about the critical windows and control of the blood pressure during pregnancy. She focused on the effective management of the hypertension in peripartum, postpartum, and during pregnancy. That require a comprehensive approach and encompasses the risk stratification, BP control, early detection, multidisciplinary approach, collaboration, patient education, and a long-term follow-up of the patient is very much necessary to get the required results from these therapies and critical window approaches. Now we are moving in our next speaker, but before that, I will invite our co-chair to introduce the new speaker. Thank you. Is she over here? Then Dr. Ellen Cynthia is invited to speak on the topic peripartum, postpartum diabetic management in women with adverse pregnancy outcome, critical windows, and target of the blood sugar control. This is very much important topic. I'm glad that this is included in this webinar. So, Dr. Ellen Cynthia.
Thank you very much, Professor. Let me share my slide. Good day, everyone. I'd like to take this opportunity to thank the organizing committee for inviting me to give a talk on this particular topic. Can you see my slide? Okay. So the topic that was given to me is about peripartum postpartum diabetes management in women with adverse pregnancy outcome. Gestational diabetes is a very common chronic illness in pregnancy that somehow impairs the health of several millions of women worldwide. In fact, if you look by history, it was first recognized only in 1964 by Dr. Mahan, and he states that hyperglycemia, if it's first detected during pregnancy, then it's time for you to say that this is GDM. With the increasing incidence of obesity worldwide, reaching actually epidemic levels, the number of pregnant women diagnosed as having GDM is fastly growing. And because of this increasing incidence of GDM, there is a wide range of complications both for the mother and the fetus that has been reported in several journal reviews. Now, this comprehensive systematic reviews and meta-analysis assessing the association between gestational diabetes and adverse pregnancy outcomes has been published in the British Medical Journal in 2021, where they looked at 7 million plus pregnancy that were evaluated with adjusted confounders, wherein they divided into two groups. One group, GDM with use of insulin, and GDM with no use of insulin. This systematic review and meta-analysis showed that the studies where insulin was not used, even when adjusted for confounders, women with GDM had increased odds of cesarean delivery, preterm delivery, low Apgar score, macrosomia, infants large for gestational age, as both maternal and fetal outcomes respectively. In women with GDM with insulin use, even when adjusted for confounders, still has an increased odds of increased large for gestational age or with respiratory distress syndrome or jaundice requiring admission to neonatal intensive care unit. Another study looking at the risk of adverse pregnancy outcomes in pregnant women with GDM was seen in China. It was published in 2024, wherein 300,000 pregnant women were selected and showed lower incidence of adverse pregnancy outcomes if these are pregnant women with GDM less than 29 years of age. There is a significant increase in the risk of cesarean delivery, abnormal fetal position, preeclampsia, as well as macrosomia if this GDM was found out in pregnant women more than 30 years of age. Now, looking in our area, specifically Asia, which is the largest and the most occupied continent, there is an increasing prevalence of GDM, with 30% of this population, in fact, encompassing the other neighboring regions. The prevalence of this GDM among the ASEAN countries depends on the population characteristics such as maternal age, socioeconomic status, race, ethnicity, body composition, screening approaches, diagnostic benchmark, as well as genetic factors. But looking at this particular graph, we would see that Thailand and Vietnam was reported to have the highest prevalence of GDM, with a median estimate of 29.2% and 17.3% respectively, followed by Singapore with a median estimate of 13.8%, in contrast with Malaysia and Myanmar, which has the lowest prevalence, with a median percentage of 8.4. Another data, looking at national data compared to hospital data, this was published in the National Institute of Health in 2020 with regards to GDM occurrence or prevalence. Singapore has the highest prevalence of GDM compared to that of Malaysia, according to the national data. However, if you look at hospital data, Vietnam has the highest prevalence, followed by Thailand, and lastly, the Philippines. You see here, we have a lot of GDM-related complications, not only maternal, but also fetal, as well as other outcomes which has been related to GDM. We also do have studies and data in the Philippines suggesting that the timing of diagnosis of GDM is very important. And if they are diagnosed late, you have higher mortality as well as fetal morbidity as well. Gestational diabetes has been a very well-known diagnosis, not only in the Asia-Pacific region, as well as in the US. And that is why you have the US Preventive Service Task Force, which somehow recommended screening for GDM after 24 weeks of pregnancy. This recommendation applies to asymptomatic women with no previous diagnosis of either type 1 or type 2 diabetes mellitus. This is a two-step screening system for DGM. So the first would be a 50-gram 1-hour glucose challenge test, followed by a 100-gram 3-hour oral glucose tolerance test. For patients with an abnormal GCT result. Alternatively, for high-risk women or in areas wherein you have higher prevalence of insulin resistance, a one-step approach can be used by immediately proceeding directly to a 100-gram of 3-hour oral glucose tolerance test. The researchers actually wrote in JAMA that the overall age standardized gestational rate significantly increased from 47.6 per 1,000 live births in 2011 to 63.5 per 1,000 live births in 2019, yielding a mean annual percent change of 3.7. GDM is characterized by an increased risk of large gestational age and neonatal as well as pregnancy complications, as well as increased risk of long-term maternal type 2 diabetes and abnormal glucose metabolism of the offspring in childhood. Offspring with exposure to untreated GDM have reduced insulin sensitivity and beta cell compensation and are more likely to have impaired glucose tolerance in childhood, increasing risk for diabetic embryopathy, anencephaly, microcephaly, congenital heart disease, renal abnormalities, as well as cardiac depression. Increase in the incidence directly is proportional to elevations in your HbA1c during the first 10 weeks of pregnancy, with lower risk of congenital abnormality, preeclampsia, and preterm. That's why it's very important that optimizing glycemic control prior to conception is important. That should be done during the 5 to 8 weeks of age of gestation. Effective preconception counseling could avert substantial health and occasional cost burden in the offspring. Individuals with pre-existing diabetes or planning for pregnancy should begin receiving care during the preconception period at a multidisciplinary clinic, and that includes your endocrinologist, your maternal fetal medical specialist, of course, dietitian, diabetes care, as well as education specialists. It is most important that diabetes-specific component preconception care is to attain glycemic control prior to conception. So pregnancy in people with normal glucose metabolism is characterized by fasting levels of blood glucose that are lower than in the non-pregnant state due to insulin-dependent glucose uptake by the fetus and the placenta, and a mild postprandial hyperglycemia and carbohydrate intolerance as a result of diabetogenic placental hormones. So in people with pre-existing diabetes, glycemic targets are usually achieved through a combination of insulin administration and medical nutrition therapy. It is important that we have to monitor postprandial because this has been associated with better glycemic outcomes as well as lower risk of preeclampsia. So what will be our target glycemic levels in pregnant women? It is less than 6%. So that's around 42 millimoles. If this can be achieved without significant hypoglycemia, then you can get a little bit relaxed to less than 7%. Additionally, your A1C represents an integral measure of glucose, but it may not capture postprandial hyperglycemia, which is the one that drives macrosomia. Thus, although HbA1c may be very useful, it should be used as a secondary measure of glycemic control in pregnancy after blood glucose monitoring. Now, in studies of individuals without pre-existing diabetes, increasing your HbA1c levels within the normal range are associated with adverse outcomes. In fact, in the HAPO study, which is your hyperglycemia and adverse pregnancy outcome study, increasing levels of hyperglycemia were also associated with worsening outcomes. Observational studies in pre-existing diabetes and pregnancy show that the lowest rates of adverse fetal outcomes is associated with A1C levels between 6 to 6.5 early in gestation. In the second or third trimester, A1C level less than 6 has the lowest risk of large for gestational age for infants, lesser preterm delivery, as well as lesser incidence of preeclampsia. So how do we manage patients with GDM? Lifestyle behavioral change is the most essential component of management, besides insulin being the preferred medication for treating hyperglycemia and gestational diabetes. Other oral glucose-lowering agents, specifically metformin or glyburide, should not be used as first-line agents, primarily because this can both cause the placenta to the fetus. Metformin, when used, yes, can treat polycystic ovarian syndrome and can even induce ovulation. But once individuals are diagnosed to be pregnant, then definitely it should be discontinued. It has also been noted that telehealth visits for pregnant people with gestational diabetes mellitus improve outcomes compared with standard in-person care. Other than insulin, lifestyle and behavioral management is essential in improving sugar control in these pregnant women. So after diagnosis, treatment should start with medical nutrition, physical activity, as well as weight management. We said earlier, medical nutrition therapy as part should be individualized. The food plan should provide adequate caloric intake that will promote not only fetal but also maternal health, achieving glycemic control and promoting weight gain as well. There is no definite research yet that identifies a specific optimal calorie intake for individuals with GDM or suggests their calorie needs differ from pregnant individuals without each GDM. The recommended dietary reference intake for all pregnant people is a minimum of 175 grams of carbohydrates, a minimum of 71 grams of protein, and 28 grams of fiber. It should be emphasized that non-saturated as well as polysaturated fats should be part of it, limiting saturated fats and avoiding trans fats. As it is true of nutritional therapy in people with diabetes, of course, the amount and type of carbohydrate will impact glucose level. So the current recommendation would be liberalizing high quality, nutrient dense carbohydrates so that it will be able to reduce postprandial glucose level, lowers free fatty acid, improving your insulin action, and somehow do have vascular benefits that reduce excess infant adiposity later on. Part and parcel of treatment will be moderate intensity exercise. So it's not only walking, but light weightlifting that can happen 20 to 50 minutes per day is recommended. That is around 2 to 7 times a day per week. Now, pharmacotherapy has been part and parcel of treating patients with GDM. As evidenced by data, it is only insulin, which is the first line agent recommended for the treatment of GDM. There are two large randomized studies in the US Preventive Services Task Force review that it improves not only women outcome, but also perinatal outcome as well. Now, there are some individuals with GDM that requires medical therapy that may not be able to use insulin safely or effectively. But during this time, there should be emphasis and discussion with regards to the known risk and the need for more long-term safety data for the offspring if patients will be started on metformin. SUs are not recommended as first-line agents for treating GDM patients. Insulin resistance decreases dramatically immediately postpartum, and insulin requirements need to be reevaluated and adjusted during the postpartum care. Now, a contraceptive plan should be discussed and implemented if, for example, these patients do have uncontrolled diabetes during their reproductive years. Screening individuals of recent history of GDM should be at 4 to 12 weeks postpartum using your 75 grams of oral glucose tolerance test. Individuals who are overweight and are obese and has history of GDM should receive intensive lifestyle intervention and or metformin to prevent diabetes. Breastfeeding is recommended to reduce the risk of maternal type 2 diabetes and should be considered when choosing whether to breastfeed or formula feeding. Individuals with history of GDM should have lifelong screening for the development of type 2 diabetes or prediabetes every 1 to 3 years. Individuals with history of GDM should seek preconception screening to identify and treat hyperglycemia and to prevent congenital malformations. Postpartum care should include not only physical, but also psychological assessment to support self-care to patients. It has been found out that breastfeeding confers a long-term metabolic benefit not only to the mother, but also to the offspring. It also reduces the risk of developing type 2 diabetes who are previously GDM, thereby improving the metabolic risk of their offspring as well. So the rising trend of GDM prevalence in general differs and somehow is basically being seen not only in the women who are pregnant, but also neonatal complications as well. There are environmental and lifestyle conditions somehow that hasten the development of this disease. And yes, it is obesity being considered a critical risk factor for chronic and non-communicable diseases. Early detection through proper screening is warranted so we can plan ahead on important measures to prevent disease outcomes. So it is a recommendation on healthy food choices, physical activity intervention that would support management of disease effectively. Communication and ensuring a clear understanding of disease risk and preventive measures should be given to our patients to provide effective GDM control and reduce maternal and neonatal complications. However, on the other hand, women who had already GDM must take full responsibility in strictly controlling their glucose levels. Failure to do so can lead to poor glycemic levels and affect their offspring as well, and eventually lead to a vicious cycle of diabetes. So with that, thank you very much for your kind attention.
For your extremely important presentation. We know that the every stage of the pregnancy with the diabetes has its own significance. Peripartum period is defined as a critical peripartum period, and it is a difficult phase for the woman with pregnancy for the diabetes management. During delivery and labor, sugar management is again essential to reduce the risk of maternal and neonatal complications like miscarriage, birth trauma, neonatal hypoglycemia, which present a unique challenge for the mother. Gestational diabetes can lead to the type 2 diabetes. So proper follow-up of women with diabetes during the pregnancy and during the postpartum period is essential, and it should be managed. Thank you so much. I will like to invite our co-chair again, Nang I Young, to introduce the next speaker and give later on the concluding remarks, please. Thank you so much, because I'm getting late for airport.
Thank you, Dr. Kaldasumro. It's really a wonderful to be in this session, and every speaker did very well. Desika and Elena, wonderful talks on diabetes and hypertension. If there is no question, can I leave? My cat patients are waiting for me.
Lika? No. Relax.
Dr. Yang, sorry, we can't hear your voice. Your voice is lost. We can't hear you.
So we are unable to hear you.
Yeah.
Hello.
We can't hear you,
Oh dear.
Miss Dr. Anand.
Now I think so. It's okay.
Yeah.
Okay.
It's okay.
Okay, thank you very much. Sorry about what happened. First of all, I'd like to thank very much Professor Sumu for a great introduction and for chairing the first 3 sessions. And it is a great pleasure to be able to join this really important webinar. And here I'd like to introduce the last but not least, the speaker, Professor Patachaya Bunchaya Anat from Thailand. She is assistant professor at the Division of Endocrinology and Metabolism, Department of Medicine, Faculty of Medicine in Chulalongkorn University, Bangkok, Thailand. Now she will be talking to us about postpartum weight management by lifestyle modification in women with adverse pregnancy outcomes, the importance of diet, physical activity, and behavioral coaching. Now we know we talked about hypertension during pregnancy and also about diabetes during pregnancy. And weight management is really important in both of these important risks. So I think what we'll be hearing next will be very, very useful to all of us. So let's give a big welcome to Professor Bunchar Anand. Thank you.
Hi, so let me share my slides here. Okay, so thank you very much for the organizing committee of APSC and also Thai Heart Association. And also thanks to all the previous speakers. You all has already covered most of the important points already. I just for my background, I am an endocrinologist and I run a weight management clinic at King Chulalongkorn Memorial Hospital, and our hospital it's coordinated with Chulalongkorn University, so it's a tertiary hospital and training hospital as well. And what I would like to share with you today is here. So here's the outline: obesity as adverse pregnancy outcomes, and also the physiologic weight change during pregnancy and postpartum. And how do we manage postpartum weight retention? As you all know that obesity is a state of excess adipose tissue or excess fat. And obesity itself, it's related to all the comorbidities, a lot of system listed here, cardiometabolic, mechanical complications, and including mental complications as well. On a slide here, you will see that fat is associated with inflammation. So I am an endocrinologist, so I see fat mass or adipose tissue as an endocrine organ that secretes a lot of adipokines and inflammatory cytokines as well. In the middle, you can see here that normal adipose tissue, it's a healthy balance of the immune cells. But once the patients get obesity, the adipocytes hypertrophy that can draw an inflammatory macrophages and cytotoxic T cells. Adipocytes can get apoptosis, and that leads to chronic inflammation, and a lot of inflammatory cytokines will come out of adipose tissues. Here are showing that visceral adipose tissues or excess visceral fat can lead to a lot of inflammatory cytokines. And that can lead to increased insulin resistance, ectopic fat at the heart, muscles, and fat. And that can cause diabetes, endothelial dysfunction, and also risk of atherosclerosis in the future. And we all agree here that showing in this picture that pre-pregnancy obesity is a risk factor for APOs or adverse pregnancy outcomes. And adverse pregnancy outcomes itself is leading to postpartum increased cardiovascular disease. Additionally, the pre-pregnancy obesity is also a direct mediated or the persistent risk factors that can lead to postpartum cardiovascular disease as well. So you can see here that weight management across, I can say, lifespan, even pre-pregnancy, during pregnancy, and postpartum is really important. Here is the graph to show weight gain during pregnancy. The graph on your left side is the normal rate or normal trajectory of weight gain during the 40 weeks of gestation. The graph on your right side, you can see here, but actually most of the weight gain are body water. But your body gonna hold on to some fat as well. So the body needs to store extra 3 or 4 kilograms of adipose tissue because your body will needs those storage of energy for postpartum nursing. So you're gonna hold on into those weight as well. Here's the table showing recommended weight gain during pregnancy. So this is based on the baseline BMI. So if your baseline BMI is underweight or normal weight, you can gain a little more weight during pregnancy compared to those who are overweight or obese at the beginning. I would like to also cover this review of literature here. It's a summary of the postpartum lifestyle intervention. So a lot of trial has been summary here. And the word that I'm going to mention to be used here is postpartum weight retention, or the weight that they have retained compared to the pre-pregnancy weight. So the key findings here is that excessive gestational weight gain is a major predictor of postpartum weight regain. So the more you hold on to the weight during your pregnancy, the likely that you're going to hold on to those weight after delivery as well. And as we know that postpartum weight regain is a predictor of future obesity and long-term health consequences. So the key findings in this study, they found listed here the predictors of postpartum weight retention. First, there's a decline in healthy dietary behaviors in the postpartum period. Imagine a busy mom, right? Your time is very limited because you have to take care of the baby, right? Eating a healthy meal, let's say a lot of vegetable, a lot of meat, and a healthy balanced plate, that will take like 15 or 20 minutes for you to finish a healthy plate, right? But let's say you grab a piece of pizza, that will take you like 5 minutes to finish that. So there's a chance that postpartum women will choose, the food that is easier, quicker. So there's a trend to decline in the healthy dietary behaviors in the postpartum period. Also, there's a tends to decline in moderate to vigorous physical activity as well. Because how can they find a time to go for a run, to go to a gym, right? But at least there's the light physical activities such as walking or household work are actually tends to be maintained at the previous level. Depression, short sleep duration, and also these negative factors is associated with postpartum weight retention. But on a living literature on breastfeeding, there's inhomogeneity. So I would say breastfeeding can be positive or negative association with the postpartum weight regain. At the end, it probably depends on more what you're taking in than calories going out during breastfeeding. In this study, the key findings of the review literature, they found that the lifestyle interventions that combining diet and physical activity are efficacious for postpartum weight loss. And the studies that have diet-only intervention are also efficacious for weight loss. But physical activity alone without dietary recommendation are inefficacious for weight loss. I think nothing too surprised here that, if you really need to lose weight, bottom line is you need to go on a diet. Physical activity or exercise will make you more healthy, but it doesn't help much for weight loss at the beginning. But it has some other benefits, right? Okay, the list of the studies listed in this review literature can go on for 4 to 5 pages, but I just want to show you here that to summary of all of the studies here, the efficacy of lifestyle intervention during postpartum period. All of that review only modest efficacy with 1 to 3.5 kilogram weight loss difference. So that's not a whole lot. That's probably about 5% weight loss, which we know that, lifestyle interventions can cause only modest weight loss, up to 5 or the more it's 7% weight loss. So, we do a lot of things. We go on a diet, we go on an exercise, but we only lose 5% of our weight. Why it is so difficult to lose weight? Okay, imagine you try to go on a diet or calorie restriction. The most difficult part is that how do you manage your hunger with very limited calorie that you want to take in? So I just want to touch base a little bit on our energy balance. Okay, here's the, just a normal graph, right? Calorie in and calorie out. We want to lose weight. We want to create a negative energy balance. But it's not as easy as that because our brain has the control of our energy homeostasis. Here's the cartoon picture of our brain. The point in the middle here is our hypothalamus, especially the arcuate nucleus areas. We have 2 types of neurons, right? The pink one is palm C. That's our satiety neurons. If it gets stimulated, we feel full. The blue one here, NPY, that's our hunger neurons, right? And how do we know when to eat or when to feel hungry or when to feel full? Our brain has to receive the signal from peripherals, right? So that's including our guts. The guts hormone gonna signal back to our brain to tell us about energy balance, right? Our adipose tissues, especially leptin, gonna go back to the brain and signals, when to feel hungry or when to feel full. But all the signals has to stay in balance, right? So look at those plates here. All the plates that I lay out here, each plate contain about 200 calories equally. But think that what kind of food that gonna make you feel full with a lot less calories. So that's gonna be, the 4 one on tops, right? The natural food high in fiber, a lot of volume, and that's, with less calories, that the things that are gonna make you feel full. The food at the bottom is calorie-dense food that's very low in volume, high in sodium and sugars. Those are high in calories, less in volume. The more you eat, but you're not gonna feel full on all those food. The food quality is really, really important. I always tell my patient that choose the right food and you're going to feel full at the right time, right? So here's the key. If they choose high protein, high fiber, and healthy food, you're gonna feel full at the right time. You know when to stop. But if you choose high dense calorie food, even though you're already taking in 200 or 2000 calories already, your body not going to feel full because you didn't get enough nutritious, and you didn't get enough vitamins and all that. You're still going to feel hungry all day long. Okay, I'm already talking about nutritious food, right? Let's say you're eating a healthy plate like this. You're eating complex carbohydrate, a lot of vegetable, vitamins, good source of proteins and all that. Your GLP-1's already, increased and gonna signal your brain, okay, you're already done. You finished your good meal already. You're gonna feel full, right? But let's say your friends are coming to your house and say, hey, I got this dessert for you. You already finished a good plate already, right? But are you gonna try this tempting dessert? So our appetite is really complex. The one that I mentioned about gut hormones and leptins and all that are homeostatic regulation. We're eating because we want to maintain our body weight. We need nutrition and all that. We need energy to maintain our body. But on the other hand, we have hedonic regulation. We want to eat because we want to feel good. All the sugars, it goes to the reward systems, and it makes you feel good because you're getting sugars, right? So that is a room for behavioral interventions. So you're eating because you're hungry, or you're eating because you're just wanting it, right? So homeostatic and hedonic, and that's a room for behavioral interventions. And don't forget that our appetite is really complex. It's not only gut hormone, it's not just sugar levels, it's the stress, depressions, lack of sleep, physical activity, all those things that, can affect the appetite as well. And imagine being a busy mom, especially in the first year, being a new mom, that's really stressful, lack of sleep and all that. So they really need helps. They really need help to control all these other factors in order to be successful on lifestyle modification. And there is no shortcut, right? You may have heard about very low calorie diet, those protein shakes and all that, intermittent fasting, or even ketogenic diet. Those, are not recommended during postpartum, especially during lactation, because they might run into a problem with malnutrition, not enough protein, and not enough vitamins and all that. So there's no shortcut for a diet in those women. Okay, I already touched base on appetite control and all that. It's not going to be easy, but it's still very important. Here's are the three pillars of lifestyle intervention: diet, physical activity, and cognitive behavioral therapy. You already may have heard about this already. This is the CDC recommendation of physical activity for all adults. But if you need to lose weight, you probably need to do more than just 150 minutes per week. Physical activity, what I mean is anything more than sedentary. So anything that is moving counts as physical activity. It does not cause much weight loss, but it's going to help with weight maintenance in the long run. And it increases fitness and some other benefits as well. Okay, what is the most difficult part of being a mom with a little baby? Time, right? Time. I always tell my patient that you can add it up in a day. You don't have to do like 30 minutes straight at one time. You can do 10 minutes here, 10 minutes there, and then it counts as 20 or 30 minutes a day. I usually use, I tell my patient, do you have a cell phone? And then I open a YouTube app, and then, hey, here you go. You can do this clip as well. Exercise with your baby, work out with the baby, or anything they can do easily at home with the baby. So that's, more practical for them to have a chance to finish it. Before I end my talk, I really like this guideline. So if you have time to take a look, here's the guideline from OBGYN of India. It summarized the key points of lifestyle modification in postpartum women. So they recommend to screen and risk assessment on the target population listed here. So female that is BMI still more than 23 at 6 weeks postpartum, those who retain more than 4 or 5 kilograms, and those with abdominal obesity or waist circumference above 80, and those with metabolic complications, fatty liver, insulin resistant, GDM, and so on. In terms of dietary recommendation, as I mentioned earlier, there's no shortcuts, but the dietary recommendation should base on eating preference, food habits, and health status. And you aim for a target calorie deficit of 500 calories per day. In women with breastfeeding, those will require additional 300 or 500 calories based on their status of lactation. But as I mentioned earlier, that you cannot rely on just breastfeeding for weight loss. You still need to counseling on what they're taking in as well. And they recommend a balanced diet between carbohydrate, protein, and fat. So half of the energy from carbohydrates and 10 to 20% of energy from protein and less than 30% of energy from fat, and a lot of fibers, as the previous speakers already mentioned. In terms of physical activity, they should resume physical activity within 4 to 6 weeks postpartum or as soon as they feel comfortable. Low impact exercise, walking or core muscle group strengthening, they can start pretty early and then slowly, gradually increase to moderate intensity, aerobic exercise and weight training. And those activities related to households or involving their baby, as I mentioned earlier. Again here, emphasizing on behavioral modifying techniques. So you need to set the goals with them, how fast or, how much they want to lose weight and what type of diets that they can do, what type of exercise and, goal setting. And also self-monitoring, anything they can do for self-monitoring, dietary, logbook, physical activity logbook. They can use a paper or they can use the app. How often they should weigh themselves, those are self-monitoring. Motivational interviewing, this is really important as well. I use this technique quite often. When you ask the questions, you can say, what do you think is your barriers for weight loss? And if I want to recommend something, I would say, I think this will benefit for you. How can you incorporate this into your routine, right? So that's more engaging and a higher chance that they will get involved with your recommendation. Also, feedback on accomplishment and achievements. I always feedback on my patients if they have lost, 1 or 2 kilograms or their triglycerides decrease and all that, I always ask them back, oh, what have you done? What have you changed? Because this looks better. So can you share your experience and all that? And I can, help them feedback on what they have changed. And it's not just only me in the clinic. You need a multidisciplinary team, including OBGYN or primary care physicians, dietitians, exercise specialists, clinical psychologists in some cases. I screen my patient and, some of the time I detected major depressive disorders as well. That's really important to be treated because depression, if it's left untreated, you're not going to be success on any of lifestyle modification or any of the treatments. Physician and endocrinologist, as I mentioned. Lastly, on the counseling techniques, this has been elaborated in many studies that face-to-face encounter, it's better than group counseling, better than video conference, and better than telephone counseling. But all in all, the more frequent you contact them, it's better than none or better than zero. So I think, how it depends on your team and how you're gonna cooperate with this, right? As a physician, I don't have time to see them every week, right? I may see them face to face, every 1 or 2 months. And then in between, they can have a group counseling or telephone, or we use the app as well. We have a line group for the app. So my dietitian can, check back on my patients. Okay, just to summarize here again, that lifestyle intervention, these are the 3 pillars. And again, you need a structural program and you need a team in order to be successful. Here's my last slides. I mentioned several times that lifestyle program is very important, but it's difficult to achieve your goal. If they don't get adequate goal on the lifestyle treatment, so in the long term, they may need additional treatment as well, even weight loss medications or surgical intervention later on in life. Again, obesity or weight management, obesity is a chronic disease that needs a long-term care during their lifetime. Thank you very much. And I'm happy to take any questions. Thank you.
Very much. That was a very great talk. I think you've emphasized the importance of lifestyle management and the management of obesity, which is of weight gain also, which is really very important to us women on the whole at any stage in our lives, but especially after pregnancy. And I think it's important that we also understand the effects of psychological effects we can have post-pregnancy, like depression, and whether or not pregnant women are getting the support that's needed. Because I think we all know it's easy, you eat less and you should exercise, but it's just so much really harder to achieve all that now. And I think it's especially great because your team, from what you've said, you've given us examples of you actually, you take out your phone and show them, what kind of exercise they can do, which is actually really good advice, as opposed to just saying, oh, you should exercise 30 minutes every day. Everyone knows that, but it's whether or not we're getting the direct instructions. So that's really very, very helpful. Here. Now, thank you very much. And I think we've all had a really, really very rewarding 2 hours spent here. As part of my closing, I'd like to thank the Asian Pacific Society of Cardiology for organizing such a great webinar. I think especially Professor Jingling Li for organizing the program. We've had 4 very excellent speakers in each of their fields of expertise. And we learned from Professor Ashraf from Pakistan that this pregnancy adverse outcome is actually the prevalence is actually quite high, up to 30%. And it's really quite under-recognized, both by healthcare professions and also by patients themselves. And there's been a lot of attention on women with cardiovascular disease, but still, that I don't think there's enough on today's this important topic, because very much is misconception that it's a male cardiovascular disease is a male problem, and also it's for women in the older ages. But as we've seen here today, all our really important problems stem from at the beginning when we're actually giving birth. And this has long-term effects on both the mother and as we've heard from all 4 of our speakers, expert speakers, that also on the baby, and also when the offspring grows up. Now, we've also heard that from our second speaker, Professor Danny, that hypertension management is really very important. And she went over all the different types of medication that are suitable during this special period in our lives, and what the hypertensive goals are. And also from our third speaker, gestational diabetes. We know that the incidence is actually rising, and the timing of identifying our patients is really important, not just during the peripartum period, but even before you actually baby is conceived. It's really important. And also the control is also quite the target is not just less than HbA1c less than 7, but actually it's important to get it less than 6. And in particular during this period, medication, there's limited medication that we can use. Preferably first line is insulin, and better to avoid sulfonylureas and metformin, especially after the first trimester. So I think that's really important. Now, I think what I feel from all of this morning is that it's not just on us cardiologists. We really need a big team to help manage our patients with adverse pregnancy outcomes, because as we know at the beginning, it's very much OB/GYN and doctors who are in contact with our patients. And so we need better dialogue, and also we need them to be aware of when to refer them to us. And also for us, when we actually see our patients, how do we manage them and follow up later on in life? And I think recently it's always been sort of advised that when we see our patients, we actually ask them about their peripartum history, because if we don't, patients don't know that they have to tell us, what they had, what problems they had. We all know how to ask for, do you smoke, do you have high blood pressure, etc., family history. But I think a lot of us cardiologists, we don't actually remember or know that it's important to ask about the peripartum and period. So I think I've learned a lot personally from our 4 experts. And I hope all the audience who would have taken time to join us on this webinar have felt the same. And again, a very, very big thank you to the APSC for organizing such a great program. I think it's really been very useful. And I hope in the future, as Professor Ashraf has mentioned, we should have our own Asian data, because it's really quite different from the Europeans and Americans. So in terms of our physiology, our customs, etc., so we can have better information to give to our for societies to give to our professions. So with that, I'd like to thank everyone. I don't know if Professor Lin would like to have any last comments or anything to say to us.
Yeah, no, nothing I have to say. I actually learned a lot. This is a field we have pretty much ignored before. I think we all have to start to really face on this problem. This is a long-term life risk reduction. I think this is even more important than dealing with just a corona event at the last moment. Yeah.
Okay. So again, thank you to everyone. Thank you, Professor Lin, and thank you, Professor Danny, Professor Delara, and Professor Bunchayatanand. Thank you, everyone. Okay, hope you all have a really pleasant day. Until next time.
Okay, thank you all. And we'll close section. Yes.